Good morning, everybody. We're going to make a start. First of all, a big welcome. This is my first ICB board meeting, and I'm absolutely delighted to be here with you. My name's Mike Bell, and I can now say that I'm officially appointed as the permanent chair of South West London ICB. And it is a real pleasure. As I think many of you know, I've got a long history in South West London. I'll know many of you from the 10 years I spent as chair of Croydon NHS Trust. But prior to that, it's actually almost 25 years ago that I joined South West London on the board of South West London Community Trust. That organisation was abolished, and I became part of South West London Strategic Health Authority. That organisation was abolished, and I became the vice chair of NHS London. That organisation was abolished. However, I have also been the chair of Croydon. I've been the chair of Barking, Havering and Redbridge, and I'm also the chair of Lewisham and Greenwich NHS Trust. Those three organisations haven't been abolished, and I'm pleased to say that I do not anticipate that South West London ICB will be abolished anytime soon. So I'm really pleased to be here with you. One of the reasons why I'm so pleased to be chair of South West London ICB alongside that history is there's a real record of success in South West London. The success in delivering some of the key targets, particularly in relation to elective recovery, but also I think we can be hugely proud of the work that has happened in South West London in terms of building an effective partnership between ourselves as the NHS, between our colleagues in local government, and with our third sector and the communities that we serve. And I think that it is about how we build upon that to create a really strong and stable future, which actually delivers for our communities and tackles the deep-seated health inequalities that exist across London, but scar South West London as they do elsewhere. So I'm absolutely delighted to be here. And looking forward to the challenge ahead. On behalf of the board, I'd like to take this opportunity to particularly thank Ruth Bailey, who has been acting up as chair for these meetings during the period between chairs. And thank you for that, Ruth. I know that your contribution is massively appreciated by everybody here. When you're speaking today, can I ask everybody to make sure that they turn on their microphones? That's in part because this meeting is both live, online, and is being recorded. If you don't switch on your microphones, you'll be silent on screen. Could I also remind people that this is a meeting held in public, but it's not a public meeting, so I won't take any interventions from members of the public until we close the meeting, and we will then take questions from the public should they have been submitted. We're not expecting any fire alarm tests today, so if the alarm does sound, please leave through the exits marked, and there'll be members of the South West London team who'll direct you towards the space. In terms of welcomes, I'd also like to welcome Zara Miloko to her first board meeting as our new voluntary sector representative. So big welcome to you. And I'd also like to note that we've got apologies from Callie Palmer, who's the partner member for specialised services, Jacqueline Totterdell, who is the partner member for acute services, Dagmar Zuna, who's the place member for Merton, and Karen Broughton, who's our deputy CEO and is currently off with COVID. Just a reminder that COVID isn't over yet. In accordance with section 4.4 of the Constitution on nominated deputies, as chair, I've agreed that James Marsh can deputise for Jacqueline in his capacity of partner member for acute services. I've not received any other apologies, and I can see around the room that the meeting is quorate, so I suggest we proceed. We will move on to declarations of interest, and we have published a declaration of interest which is included in the pack and on the board. Can I just check whether there are any additional? And I think, Joe, you wish to make an additional declaration.
It's not a declaration of interest, Mike, but can I also just welcome you on behalf of the Chief Execs and the senior management team within the ICB. As you've accounted, you're absolutely steeped in South West London, the community, and you're totally committed to doing the right things for the communities that we serve and driving forward our partnership relationship. So now that you're officially here, I think we're really excited and really pleased to be embarking on this next stage of our journey with you. So thank you.
Very much appreciated. Thank you. Thank you. We'll move on to the minutes of the last meeting, which was held on the 15th of March. And can I just check that people are comfortable with the minutes and have no amendments, and we can approve them? Thank you. As you can see, the action log is attached, and there is nothing due for this meeting. So we'll come back to those items in July and then September. We'll move on to decisions made in other meetings. And Sarah, could I ask you to summarise the paper attached?
Yes, so normally we would have made this decision in public. However, we were requested to pass by our board our operating plan and our financial position for next year by NHS England, by our regulators, by the 4th of April. So we had to, 4th of May. So we had to do a meeting outside of the public meeting. However, the papers are available online, and Helen will update on the financial position when we get to the finance details. So we signed off both the financial plan and the capital plan, and we also signed off the operating plan for 23-24. And as I said, those papers are available online.
Any questions for Sarah in relation to those decisions or the papers? Great, thank you. So we'll move on to the Chair's report. And as you can see, there's a written Chair's report. Whilst I've actually only been in post officially for 2 weeks, I haven't done all of these things in just 2 weeks. I've been undertaking 1 or 2 things beforehand, and this provides a bit of a summary of some of those meetings, etc. Sarah and I have been having a series of meetings with all of the leaders and chief executives of local authorities, and we've undertaken 5 out of 6 of those, and they've been incredibly helpful in terms of establishing and confirming our commitment to a partnership with local authorities. In addition to that, I wanted to highlight just 3 things from the Chair's report. The first I'd like to highlight is the visit that we made to Springfield, which was a truly astounding visit. Worth highlighting today because we have the mental health strategy coming forward. I'd particularly like to thank Vanessa for the really warm welcome that we received on that visit. And it was absolutely stunning to see the new development there, the absolutely first-class range of services that we have for our communities that need acute mental health interventions, and the broader therapeutic environment in the way that the estate has been developed. I'll be leading a visit to Springfield on Monday of next week with the NHS London Anchor Development Group to show them just what capital developments can look like in the NHS. And I think that's a real testament to what's been achieved in South West London. So a big thank you to South West London and St George's for their warm welcome. The second area I'd like to touch upon, and Callie isn't here, but we also did a visit to Royal Marsden, and it was a hugely impressive visit looking at the various life science capacity they have there, as well as the core cancer treatment services. Hugely impressive, and it was also a great opportunity to look at the new site that we are still anticipating for the new hospital, and really important. We are hoping that there will be a decision from government supporting that in the very, very near future. And the final item I just wanted to highlight from the Chair's report was I had the privilege of speaking at an event last Friday evening, the Turning the Tide event. You will all remember fondly our former chief nurse, Gloria Rowland, who left a couple of weeks ago. She had led a piece of work across London called Turning the Tide, which was about increasing the number of senior black midwives in both in London and nationally. When she started the programme, out of 200, more than 200 midwife nurses, senior directors of midwifery, there were only 7. 2 years later, 27 of those roles were held by black women. And I think that's a major, major achievement that signals the passion that Gloria brought to that. There is still further to go in making sure that we're creating top opportunities for our black and other ethnic minority staff in all of the senior nursing and other roles within the NHS. But it's a testament to how far you can go with the commitment and the strong leadership. So I'd like to also thank Gloria for her contribution to the work of South West London since its inception last year. I will now move across to the South West London mental health strategy. Vanessa, I think you're leading this. I'm not sure if you're going to be joined by Amy, but a big welcome to Amy if you are. Yeah. Over to you, Vanessa.
Right. Okay, thank you. And thank you for your kind words about Springfield. And I guess the basis of the mental health strategy is that actually it's not just about us as a mental health trust and provider or South London and the Maudsley. It's about the whole community and what can we do. And I hope that through reading the strategy that brings us to light. I'm delighted to be joined by Amy, who has been fundamental alongside other colleagues in writing this, so I really can't take too much of the credit personally. I'm taking it that it's read. You will have seen that there's also a summary presentation that I hope that you have found helpful, but there are just a few points that I wanted to draw out. So it is a comprehensive all-age strategy. We've done significant engagement with our population, and I hope you can see the read-through for that. We've done a full baseline position of mental health services and performance and spend. And we were asked to be ambitious, and it certainly is ambitious. And I guess this is one of the areas that we perhaps want to be thoughtful about, because we have to be steeped in ambition and reality, don't we? So with a 10% spend on mental health against an average of a 14% spend, we need to be ambitious and realistic. And I guess I'm asking you to think about that as we move to signing this off today. We understand that we need to do this within existing resources. That is very clear, particularly given our financial position, but not just around the finances. It's also around developing services with a workforce that can cope with the pace at which we need to develop and change services. We've included a strong preventative element, in particular in relation to our child and adolescent mental health provision. And that's really important. That's particularly important in terms of the conversation we need to have at the ICP and how we get prevention through everything, because as you will have read through the report, between the ages of 14 and 25, if you have a mental health difficulty, you're much more likely to go on to have a severe and enduring mental health challenge. So if we can make things different for children, that could really make things different for the future. There's strong reference in here around health inequalities, but we need to be thoughtful about that in terms of how we manage our resources. So as we look to realise the year 1, 2, 3 delivery plans, there will be a need to think about how resources are distributed in a way of health inequalities, need, and to deliver parity, and that's a challenge for us, because that will be different from how we have necessarily done things before. So it's the challenge is not uniform across our 6 boroughs, and you will have read and seen that, but it's clear that what we need to get towards is parity of outcome and offer. So it's here for your approval today. I have kind of 2 or 3 key questions for you to perhaps have in your mind as we go into wider questions. So the first is, how are we as a board and system actually going to lead and deliver this differently from what we've done before, because it's going to take all of us. The second is, we were asked to be ambitious for children. Have we been ambitious enough? And are we all committed to doing the hard work that's going to take? The third is more of an acknowledgement that distribution on need and health inequalities to get parity is going to challenge all of us as we have to move resources across boroughs. So just to be thoughtful about that. But I'm happy to take any questions.
Vanessa, thank you. And I think the ambition that you've talked about there is really strong within the strategy, and that's fantastic to see. If we could maybe look at the children and adolescent mental health component first, and I'm looking towards Ruth, because Ruth is the co-chair of the ICP, and one of our strategic priorities within the ICP is children and mental health services. And Ruth, when Sarah and I met with you and your chief executive in your place role, we also had a good discussion around children and adolescent mental health. I wonder if you'd like to say some words around that.
Thanks, Mike. And we do recognise the constraints, Jacqueline and Amy. 10% spend, there's no evidence that I'm aware of that need is lower in South West London. So we're really going to have to think about how we use the resources that we have. Smarter is the in word, but we know what we mean, more effectively. I'm a governor at a local primary school. I can see the impact that COVID has had on both pupils and teachers, and we've seen the absence rate, which is increasing sadly, which isn't generally a feature in South West London, but the absent rate of pupils is increasing, and I don't have any data, but common sense will say those children that aren't going into school are exactly those children who need to be there. So I do think we need to think more about prevention. To be fair, in the overall scheme of things, the amounts of money that would make a difference aren't huge. So let's think about how we can work with the schools to understand what would work best. There's a very interesting pilot going on in South West London, putting counsellors, not counsellors, counsellors in schools. I haven't seen an impact assessment of that. Be interested to see how effective that has been. But I do think if we are successful in providing support to youngsters early on, we all know that's going to make such an impact, and means that the services you provide will be able to focus on the people that have that higher level of need. So it is about shifting the dial towards prevention. And I would say, given the financial constraints, is even more immediate and urgent. And we need to think seriously about how we're going to do that. Thank you.
Take some other comments. Yes, Charlotte.
So, Charlotte Vaughan, Exec Director of Communications and Engagement. So I did want to just comment on the engagement that you've done with community. So not only the volumes in that you've spoken to over 1,000 people in developing the strategy, but the feedback, I think, from communities into the strategy. So the actions and the plans can be directly correlated. And I think that is difficult to do. And I just wanted to say that has been noted by the engagement community in South West London. And I think we can all learn from that. And I know that we'll be working with you to kind of make sure we do that on implementation. But I just wanted to say that was a very big piece of work, and all of that isn't detailed in the paper, but we thought it was an example of real best practice.
Thank you. It's definitely worth noting. One of the key areas, of course, for mental health is the interface with physical health services, particularly at the very acute end. I'm wondering if James, as the representative of Acute Partners, might want to say something in terms of his hopes for the strategy in relation to the impact upon things like A&E.
Thank you, Mike. And we had discussions at the South West London Chief Execs meeting, and we welcome the strategy. We welcome the approach to proactive care and reduced avoidable attendance at ED, and suitable support for onward placement for patients if they need ongoing mental health care or care in the community. We also discussed the interface with patients who have a serious mental illness and comorbid medical conditions, and welcome the very proactive approach to ensure that there's joined up care within all of the places in South West London.
Thank you, James. And I'm wondering, probably worth noting that South West London St George's covers 5 of our 6 boroughs. One of the borough that isn't covered is Croydon. And I wonder if we could just hear from Matthew as the place lead for Croydon in terms of how the strategy might be implemented there with our partner SLAM.
Thanks, Chair. And I'd endorse comments made by colleagues about the importance of this and the good work that's been done to produce it. And I know that the work has been done not just from a South West London St George's footprint, but with Croydon in mind, and they've been fully engaged in that process. So I'm grateful for that. And to that end, I would be supportive of this work, and we'll be pursuing this, obviously, with SLAM colleagues, but also with Vanessa in her sort of overseeing role. I would perhaps highlight 2 quick points in addition. One is, I would fully endorse the focus this year on CAMS, looking at the pressures coming through on children and young people post-pandemic. I don't think we can underestimate the change that has appears to have created, and certainly that's the experience that I see in ED, but also I know that that's just one tip of the iceberg. There's a whole pathway before and after that that we shouldn't and won't forget either. So I think that focus on child and adolescent mental health, absolutely right for this year. You'd expect me to say it, Chair, and if I didn't, you might say it, so I think I should do, which is the health inequalities piece is massively important. It is a fairly mixed picture in South West London, and from a Croydon perspective, we look forward to ongoing discussions about how we can address that, and I note with interest and support the need to balance resource allocation, and I know that's tricky, but I know that's what we need to do, and we'll be supportive and pursuing that with Vanessa and colleagues from SLAM.
Thank you for that, Matthew. James.
Thank you, James Blythen, place member for Sutton. I also welcome the strategy, and I recognise a lot of things that we've had an opportunity to work through within Sutton, not least because Amy is a member of the Sutton Health and Care Executive, and that helps us immensely. And we've also had a number of opportunities to work this through at our Health and Wellbeing Board. I think building on Matthew's point, I think that one of the ways that we will need to work through the health inequalities piece is to really focus some interventions at a very local level and reflect very local need. And that's why I really welcome the inclusion of integration with neighbourhood teams within this. I think, Chair, I think the challenge for us as a board is how we work on creating a framework whereby we understand what interventions we make at system level, we understand how we work at borough level, but we also create the space and the framework to allow interventions to be tailored at neighbourhood level as well. So I would draw attention to that as something that from a system leadership perspective, I think we will need to pay a lot of attention to successfully implement this strategy.
Thank you for that, James. I think some really, really helpful comments. Are there any other comments that people would like to make? I'll come back to Amy and Vanessa to see if you want to make any concluding comments before handing over to Sarah.
Thank you. So I guess I'd like to first of all thank everyone that's been involved in participating and completing the development of the strategy. It's been a long piece of work, but actually the work begins now, as Vanessa said at the beginning. I think our challenges moving forward are going to be, kind of as James has indicated, balancing what we do at system level, what we do at place, and what we do at the most local level around our neighbourhoods. And we would also really value ongoing engagement and ongoing involvement from our communities, from our places, and from our colleagues outside of mental health to move this forward. So thank you, and if there is anything more that we can do as an ICB or trust or wider team, please let us know. Thank you.
Fantastic. Vanessa.
No, I think it's now for us to go ahead and deliver, isn't it? One of the things I'm really proud of is that the strength that we've got across the South London partnership with SLAM, Oxley's and ourselves that has been a bedrock, but also the mental health partnership delivery group that's established. So I think we've got the right structures to do it. So with your support, we will go fly for mental health. Thank you.
Thank you. Sarah.
Yeah, so thank you to Vanessa and Amy and the teams and everyone across South West London that's fed into this work. I think it's really important that this is a big priority for us in South West London. We recognise, particularly around children and young people, that this is an area that we want to focus on, and that the importance of mental health is as important as physical health when we are talking about our local people. One of the things I would like to raise just with the two of you and how we take forward is sometimes I think we measure our need based on the length of waiting lists and so on, but actually we have some deprived communities where they don't even access services. So I think we need to think very widely about how do we identify the inequalities that are out there and how do we make sure that we support people in a different way. And I think that's particularly the case in Croydon, we know that. So I do think we need to think very widely about how do we support people in a different way. And as you say, the main thing now is that we get on with delivery, and I think that this is a really great start for our programme. So thank you.
Thank you. So I'm seeing a huge amount of enthusiasm for this strategy. I'm assuming people are happy for us to endorse it formally as a board. And just a big thank you to Vanessa and to Amy for this really massive amount of work that's gone into this, and for a really, really strong and ambitious strategy. And as you say, Vanessa, the hard work starts now. We'll be looking forward to updates on progress. Okay, we'll move on to the next item on the agenda, which is the South West London Primary Care Strategy Update. And I'm going to come to, I was going to say to come to Mark, but I'm going to come to Annette because you've been leading this work, I do believe.
No,
Nicola, sorry, Nicola. Nicola, apologies.
That's right. Morning, everybody. I'm Nicola Jones, and I'm a GP. And I'm the clinical lead for primary care for the ICS, and I'm joined today by my colleagues Mark Krillman and Andrew McMillan. And today really is an opportunity for us to consider the part of the healthcare system that deals with 90% of the patient interactions in the NHS, 90%. So it's really important for patients and for the rest of our system that we have high quality, accessible general practice services. And patients tell us that lately it's hard getting to see their GP. In March, there were 750,000 appointments in our practices. That's more than ever, and yet demand is exceeding supply. And there are some reasons for this. So recruitment and retention across all professional groups is really difficult, especially of GPs. Patient demand is high. It's driven by increased frailty and complexity. It's driven by the backlog of need from the pandemic. It's driven by the waiting lists in the acute sector. Workload is high in general practice, bureaucracy, changes in clinical pathways, failure demand from elsewhere in the system, and failure demand from within primary care itself contributes to this. And there's an increase in work which was previously done in secondary care and has, for very good reasons, been moved closer to patients' homes, into primary care, and this has all created an increase in work. And of course, pressures felt elsewhere in the system, in mental health, in ED, in social care, in community services. All these pressures are very much there at the moment, and they're all felt in primary care. But there are lots of opportunities here because this position of general practice at the heart of our system, although it's currently very challenged, is exactly where we should be putting our resource and our energy and our focus, because excellent general practice, which is properly supported to do its job, will enable us to deliver better care right across the system. So our aim today is to generate the discussion here at the board to set the direction of travel. And you might know that the primary care recovery plan was published last week, having been delayed for months. It arrived 2 hours after we circulated our slides. However, it does support our thinking, and the funding it describes will be needed to support this plan. So we're asking the board really what our level of ambition should be. We've described in the slide pack one that improves health outcomes, it reduces clinical variation, and it delivers a positive patient experience as a minimum. I think we've got no choice but to be more ambitious about what we want our practices to deliver, because our future health and the health of our whole system and our patients depends on it. So we'd like to hear from the board about that, and we're framing the discussion in terms of some key themes and enablers which we developed in a whole system summit in November, and they're access, prevention and proactive care. So Mark and Andy are going to cover those in detail, so I'm not going to do the detail, but I just have 2 important issues that I wanted to talk about as well, which is testing with you the concept that as we improve access to general practice, where there's a lot of heat in the system and a push to do that, and it's absolutely right. So as we develop this proactive care and prevention, it seems really important to me that in our urgency to improve patient experience, we don't just improve care for those people who already had better care. And I think it should be front and centre of our plans, and I'd really like to hear from the board about whether you'd agree and support that approach, because we really need to address health inequalities. And secondly, we want to address how, as we put in place plans to improve access, we secure continuity of care. And that can be contentious because not always appreciated how much it can achieve. There's an association between having the same doctor over time and what we call hard endpoints: mortality, hospitalisation for emergency reasons, attendances at ED, presentation out of hours. And studies have shown there's a direct link between seeing the same doctor and a reduction in those events. And it is particularly the work has been done regarding doctors. If I review a letter or a pathology result for a patient I know well, it's going to take me a fraction of the time that it would take a non-familiar clinician. It's very clinically efficient to have continuity of care, and we know that it increases job satisfaction, which in a system where recruitment and retention are difficult, that's really, really important. So I think in getting the right balance between access and continuity is a really important consideration. So just a quick word on scope. We haven't included at this point in this discussion dental, pharmacy and optometry services. They're a really important part of a comprehensive primary care strategy, but we've had delegated responsibility for 47 days, and we're going to need to spend a bit of time considering that before we realistically develop a strategic approach. And we're not intending this discussion to be about delivering everything. It's not about the big programmes of mental health, of cancer, urgent care, because they've all got, as we've heard, their own strategy and plans, but they also have a very significant general practice element on which much of the rest relies. So the discussion we need to have today is how to ensure general practice is strong and capable so that it's the sound foundation on which the rest of our system can be built. And finally, to say that improving and modernising operational efficiency of general practice underpins many of the ambitions that we have. And it's not going to be easy to effect this massive change programme in the face of workforce and workload challenge, but this is what we need to do, and we're going to need to support practices and PCNs to enable them to deliver that. So I'm expecting lively interest from the board on this topic, but first I'm going to hand over to Mark to provide a bit more content.
Thanks, Nicola. I'm Mark Creelman. I'm the Place Executive for Wandsworth Board and also the SRO for Primary Care at the ICB. I think Nicola probably stole all my thunder, actually, and has covered quite a lot of what I was going to say. But I do just want to touch upon the three elements of the strategy, which are prevention, proactive care and access. But that's in an environment of addressing health inequalities, and it's really important that we return to that, not unlike the previous conversation about mental health. When we talk about prevention, we've got to recognise the voluntary sector contribution in prevention, and actually they are often the people that can reach into the communities that we're trying to support. In terms of access, we've got to address same-day access as well as routine access as part of the strategy. And then in proactive care, we talk about integrated neighbourhood teams as a must-do. But within that, that's multidisciplinary teams and also continuity of care, as Nicola's mentioned. With the primary care access recovery plan, we will roll that into our strategy. But a couple of points just worth noting, and that's really tackling that 8 a.m. rush that everyone describes around not having to phone your GP at 8 a.m. in the morning and then you missed it, you have to go back the next day. But also it really clearly states that there is an enhanced role for pharmacy. So although we've not incorporated it, I think the next iteration of the strategy needs to incorporate that. I just want to probably finish on the fact that we do have good primary care in South West London. It's really important that we recognise that, and the quality indicators support us on that. But we have a way to go as well. I'm not going to, I think the discussion is the really important part, so I'll hand across to Andy.
Good morning, everyone. I'm Andrew McMyler. I'm the Director of Primary Care for the ICB. Just wanted to touch on a few slides, particularly around the self-assessment, so where are we now? proactive care is something that I think if we do proactive care really, really well across South West London, it really helps the rest of the system. It's kind of the blueprint of everything we need to be doing. We have some great examples already in Kingston and Richmond with the NET. 2 PCNs looked after 650 patients on their MDT caseload across health and care. And over 4 months saw their unplanned care usage down by over 40%. Now, if you kind of factor that in across all of our 39 PCNs, that's huge potential in terms of helping the rest of the system out. We have over 173,000 people in South West London with 2 or more long-term conditions, one of which may be moderate or severe frailty. And we think around 4% of those will benefit from the proactive care approach, which is around patients who have regular unplanned care usage, also those that experience health inequalities as measured by the core 20 factors, which are also included in the slide pack. And proactive care is absolutely fantastic because it's really what GPs and health and nursing care teams want to be doing with their time, actually. Spending time with the patient, understanding the patient, what's important to them, their carers, and really what's in it for them, as opposed to simply just getting appointments through the system day after day. So that is something that we're absolutely committed to be driving throughout our 39 primary care networks over the next period of time. Access, obviously it's all about access at the end of the day, regardless of what the presenting complaint is. And whilst we're really happy that we are above the national average in terms of the patient survey, over 85% would recommend their GP. They've had a good experience, and over 90% to wider family and friends. We do recognise, of course, there is plenty more scope to go. And obviously, where 10% aren't happy with being able to access care, that is clearly 10% we need to work on. But in terms of some of the broad brush figures, we had in March 2023, 752,000 appointments delivered in general practice, which if you compare that to March 2019, so pre-pandemic, that's an increase in over 40%. So a huge increase. And I think in that time, the funding for primary care in terms of additional roles has increased by around 10%. So it's a real productivity step change that general practice and primary care networks are able to develop as well. And then just a quick word on face-to-face appointments, which you, of course, have all seen dominate the news headlines over the last few months. The face-to-face percentage rate of appointments in primary care is currently around 66%, which is the highest in London. Not saying that's good or that's bad, but it certainly goes to show that we're getting back to sort of the pre-pandemic levels as well. We still do have a lot of work to do in terms of really engaging with our patients, but for example, just up the road, Battersea PCN, a few months ago they did a patient survey where they asked patients how they wanted to access and when they wanted to access care, and they now put on double the number of appointments on a Saturday morning compared to a Saturday afternoon because that was what the requirement from their patients was. And that was at a time when lots of PCNs were working about how they wanted to deliver care for their patients, which resulted in over 40,000 patient surveys at the end of last summer, just enabled to help PCNs develop how they can offer their care to their patients, which might be of a Friday morning community clinic for some or a paediatric afternoon clinic for others as well. Prevention, I think, is certainly an area that we can all agree that we need to do more on, certainly since the pandemic days. We have made really strong inroads, particularly in terms of 2 of the key indicators. So learning disability health checks for those people aged over 14 is now over 60%, which is back to and delivering beyond the pre-pandemic levels, and we do have plans to go even further. And just last month, we rolled out a really fantastic good practice SMI health check for really vulnerable people, and that's 6 core health checks culminating in a really detailed comprehensive care plan and assessment plan to really deliver best quality, best practice for those people as well. Just a word on digital. So I don't know how many members of the board have accessed e-consult or an online platform in their practice, but it's something that we've really worked hard to develop across South West London in the last 3 years. I think that Charlotte and her team have done some really good case studies for the NETS practice, where we've been able to see an extra 200-300 patients through a week by being able to help better manage people who fill in a little form online, perhaps attach a photo. It goes to a central sort of triage function, and then that patient is responded to usually the same day about how their request is then going to be managed and dealt with as well. And we've also recently rolled out 2-way messaging where you can send a photo to your GP, the GP can write back and you can have a nice conversation with the GP and they can work out how best to get their care to you as well. We still have more work to do with the NHS app. I think we made, again, huge strides. So the NHS app is really meant to be the single front door to how you access general practice. So you can order, for example, your repeat prescriptions. About 9.5% of our prescriptions are done online at the minute, which is, again, a big improvement from 3 years ago, but still a lot more to do. Our NHS app usage has increased by about 10%. We did a comms campaign with Valentina and Nicola and Charlotte's team. Did geo and macro targeting, whatever that means, but it delivered about an extra 10% in increases as well. And workforce, we're clearly nothing without our workforce in general practice as we are across the rest of the system. And we're hugely proud that we've increased our workforce by about 18 to 20% in the last few years. And we now have 53 first contact physios in primary care networks, which we've, again, never had before. So they're fantastic because they can help diagnose and assess your MSK problems, a lot of the common back and musculoskeletal injuries that people have as well, and help get people the care that they need a lot quicker as well. We also have 42 mental health practitioners, which again, back to the previous conversation, really help in terms of that initial first point of contact. And we have plans to recruit a lot more over the coming year. And we have 127 care coordinators as of April, which will be fundamental to the building blocks for our proactive care. So really helping be that central point of contact for those vulnerable people that really need that personalised care. And then if I can finish just a word on the same-day access. So Mark talked about the primary care recovery plan. So in a nutshell, this is for patients to know on the day they contact their practice how their request will be managed. So if their need is clinically urgent, it should be assessed on the same day by telephone or face-to-face appointment with an appropriate clinician. Or if it's not urgent but requires a telephone or a face-to-face, it should be dealt with and scheduled within 2 weeks as well. And one of the key enablers for this is something called cloud-based telephony again, which is a really fancy call centre idea where if all of us in this room worked with the same GP practice, we could be in our homes, we'd all be able to kind of look at the same system, work with the same number of patients, and it really helps with that resilience. And also what it will do is when a patient gets into your surgery, you'll be able to work out who is the best person able to respond to that individual request. So it will stop all the people being put through to one central number and being told, call back later, call back later. It will really help in terms of people in that practice and that MDT skill set to be able to get the patient to the right point as quick as possible. And then finally, in summary, we know primary care is not an island. It really is an essential element to everything we do across the system. We have come a long way, certainly in the last 3 or 4 years, and I think the whole work of people, not just in the ICB, but practices, PCNs, community pharmacy, others in their team, has been really exemplary. But we do know, as Nicola's articulated, there are still huge challenges, whether that be workforce or patient expectations. And the recovery plan really sort of helps us get into our consistent footprint. So we know that everyone in South West London is going to be able to access that really good, high standard quality of care that we already strive for. And that's really the purpose of the strategy.
Andy, Nicola and Mark, thank you very, very much for that presentation. I think many colleagues will be aware that I've made it very clear since, in conversations since arriving, that I see actually that ambition that you articulated, Nicola, of shifting the balance of resource from the acute treatment services into earlier intervention, preventative healthcare, and anticipatory healthcare. We cannot do that without our colleagues in primary care, particularly within general practice. So it's good to see a strategy beginning to articulate the journey that we want to make as far as general practice goes. Really pleased to hear that we're going to, in the next iteration, expand that to include pharmacy, optometry and dentistry, really key components of primary care. I suppose I would also be hoping that we would also begin to look more closely at the inverse care law, which starts in primary care with the number of general practitioners in the most affluent communities outstripping, often doubling, the number of general practitioners in the least deprived areas. And that, of course, as the key gatekeepers to planned care in other parts of the service, means that we are embedding inequalities if we don't tackle that. So I would hope that we will have some really big ambitions in relation to both the allocation of resource between acute and primary care, but more particularly within primary care, between those areas of affluence and those areas of greater deprivation, and ensure that we have equity in that provision. I think there's also something, again, Nicola, you touched upon it, in terms of making sure that our general practice, our PCNs, are really closely operating in multidisciplinary teams with our local authority and voluntary sector colleagues through their neighbourhoods. And I would hope that our strategy as we move forward would have some ambitions about aligning the PCN footprints with the other neighbourhood footprints offered by people like local authorities. But then my initial observations, it's fantastic to see this. I think the three priorities in terms of access are the right ones. In all of the conversations that I've had with politicians in South West London, the key issue that they are getting from their constituents, be they MPs or local authority councillors, has been in relation to GP access. So we need to make sure that we're addressing that concern. There, of course, is a significant opportunity to prevent ill health, and that rests with our colleagues, particularly in primary care, general practice and other parts of primary care. And we have a big ambition in relation to population health management in South West London. That provides us with the opportunity for proactive and anticipatory healthcare. That is the role of primary care. So it would be really exciting to see that enhanced and developed as we move forward. I'm going to take comments from colleagues. I know Mike is keen to come in with some comments, and I'll bring in Ruth afterwards, and John.
Thanks, Chair. So, Mike Jackson, I'm the Local Authority Chief Exec Rep at the board. I'm Chief Executive for Richmond and Wandsworth, so it was nice to hear the name check for Battersea and what's going on in the borough there. So I very much welcome the strategy, particularly the focus on prevention. And I just wanted to build on the point Mark made about the importance of the voluntary and community sector, which perhaps hasn't had as much attention in the introductory remarks. And I think it's really important that we remember that in the first instance, we want to support residents, ideally before they become patients. So it's just a shout out really for the work we need to do with the voluntary community sector in terms of that broader sense of prevention. But I'm very supportive of the strategy. Thank you.
So if I could go to Ruth next, please.
Thank you. So building on James's point earlier, I think the connection between both the mental health strategy and the primary care strategy is how we develop that framework for making decisions around where we prioritise shift funding in order to respond to the health inequalities. And I do think that's something that we can do at a system level, as James said. And then my next point is a question about the digital maturity. So really interesting to hear about the work that's going on, but I'd be interested in how we see the maturity levels within South West London. What's the capacity for further work to drive efficiencies, smarter working, and bringing kind of patients some of the services in their homes?
Thank you, Ruth. And if I could go to John next.
Thank you, Chair. Thank you, Chair. One observation as we head towards the NHS 75th birthday is that sometimes we're very good at looking back, and sometimes there is a rose-tinted view of what the past used to be like, and that applies to general practice as much primary care as much as anything else. So I think the important thing to note is actually in South West London things are very good. That's not to say there isn't an ambition to get better and there aren't some challenges, but primary care has been evolving over the 25 years that I've been involved in it, and it's great to see some of that work being reflected in this particular document. But the challenge then for primary care is that it is subject to the nuances of what's fashionable, what's here and now. So digital, let's say 10 years ago, we would have desired, let's say, lots of more online consultations because that's what the population would have liked. But then there was a tension as online consultations come in as why things can't be more face-to-face. So there is always a challenge there for practices and operational teams to think what is the balance between embracing modern technology approaches and perhaps what is a historical way of delivering care. So the other point I just want to make in terms of we talked about the mental health strategy, I think if you were to read our ICP key priorities and you'd look at our primary care strategy and you would see prevention and self-management right as the top of the list of things we to do. So it's good to see that golden thread, and particularly with enablers around digital and workforce coming through as well. So it's almost like we are writing these documents in parallel, which is what we need to do to enable the change. So we are in a good place. We need to do more, and it's probably going to get harder before it gets better, I have to say. But I think just recognising that so much care takes place in primary care, that's where our focus needs to be, and I welcome this document.
Thank you, John. And if I can go to Annette next.
Thank you, Mike, and thank you, Andy and Mark and Nicola. And I think this is a primary care strategy, absolutely, that I support, but I can also say that certainly GPs in Kingston support it, and Andy did come and talk to us, and I think that everyone sees the value and feels that the areas of to concentrate on are the right ones. Operational efficiency, I think, is key. We need to be working on that, and digital enablers will help us to do that. I think what we need to do is understand that digital enablers don't mean that every consultation has to be remote. What they help us to do, and I think one of the ways to use the digital tools that we have and to use them more and better and more effectively is to help us to triage the demand coming in on the day, and then to be able to direct people to the right care for them at that time for the complaint or issue that they have. And as a result, in our practice, we're able to see 90% of people who need to be seen in the practice face to face. So I think that it's how you use those digital tools, and I think they are going to be key and crucial going forwards. So I think we're right to concentrate on digital. Prevention and proactive care. Prevention is absolutely essential to sustainability going forwards. And so while it takes a long time, I think sometimes for us, we feel that prevention takes a long time to see benefits. It is something that we have to concentrate on, and something that primary care has to concentrate on. Proactive or anticipatory care is crucial now, right here and now. It can deliver benefits for patients, providing holistic care, and I absolutely agree we need to do that and are doing that in conjunction with partners in adult social care and in the voluntary sector. That is how we have set our model up, and that is how many of the models around South West London are set up. And going forwards, that multidisciplinary way of working not only provides benefits for patients, but it provides real benefits for job satisfaction, continuity of care, and it will help us to retain our staff. And that people want to work in primary care because they want to work in their local communities and do good things for local people and to help them. And I think we need to help make primary care somewhere where it's possible to feel happy working again, and possible to feel that you're actually able to get those outcomes for your local population.
Thank you for that, Annette. And I think that's that aspiration of actually making it a great place to work again is really, really important. If I come to Dick now.
Thank you, Mike, and thanks very much for this report, which seems absolutely on focus. Proactive care, preventive care, and accessibility. Key things going forward. I think I'd probably add within the accessible, empowering people when they engage with healthcare, helpful in making the quality of access go up, and probably helpful in reducing demand. The three linked things I just wanted to say was, it struck me that as the strategy develops, it'd be good, the more ambitious we can be about finding some outcomes to stick in the ground where we're setting ourselves goals that we don't necessarily know we can achieve. I'm looking at slide 10, which has some very impressive statistics about reducing unexpected A&E attendances in Kingston by 40%. Now, that's a powerful thing. That's the sort of outcome goal that if we stick it in the ground now, it helps drive us. And I suspect it's likely to do two things. Firstly, to highlight how important it will be to change the way in which we work, and that will have implications for a workforce that speak to what Annette, you just said about making it a different and better environment to work in. It will also throw up challenges that we, the board, will have to address to facilitate that change. And that leads me to my final point, that it does seem to me that going forward, this is part of, or it poses a challenge for us as a board to tell the story of change to people across South West London in a way that will make them embrace it, rather than be concerned that this is the next bad thing that's going to happen. Because we need to change quickly if we're going to meet any really important outcomes.
Thank you for that, Dick, and I think it is really important that we establish some tangible goals and outcomes, not least to using your example of 40% reduction in A&E. If we can achieve that, then actually we can release a significant amount of funding, which allows us to begin planning for that move towards a transfer of resource between acute and primary, community and other early intervention services. If I can come to James next.
Thank you, Chair. So I support everything in the document, but I think that we need to challenge ourselves as a board around this issue. I mean, what we've talked about is access, particularly to support people where there's health inequalities challenges, needing continuity as well, needing it with a constrained workforce and needing it within financial constraints. And I think there are a number of things that are in tension there. Evidently, there are a number of things that are in tension. And I think we need to challenge ourselves in terms of making sure that we have a general practice landscape that is best suited to meeting all of those different challenges. We serve an incredibly diverse population, and quality and access don't mean the same thing to all the people that we serve. I think that this strategy will help us within our current general practice infrastructure deliver on more of those things. But I think we should challenge ourselves as to say, have we got the right general practice infrastructure? You know, we know in some places we've got the ability within general practice through scale to do more of those things well, because we have more consolidated general practice, but we've got a very, very diverse general practice provider landscape at the moment. So I think the challenge for us is to make sure that while we do things that we can do within that current infrastructure, we also think about how might our primary care landscape need to change so that we can really do all of those things for our communities that we serve to the very best of our ability, and you know, how do we address those different dimensions of quality and access in a way that really addresses the needs of those different communities that we have within South West London.
Thank you, James. So a challenge there for a little bit more challenge, a little bit more, yeah. Okay, Martin.
Thank you, Chair. Martin Spencer, non-exec member. I wanted to build on Dick's last point, actually. So, I mean, I welcome the strategy and the initiatives in here as well. And a communications programme was referenced in the introduction. And I think that's really important. And I wanted to ask what the communication plan is going forward, because I think it's so important that we have a parallel communication plan to drive uptake and drive awareness of these initiatives so that we can achieve the benefits both for residents, for patients, but also in terms of our other objectives for the ICB, in terms of financial objectives and the other objectives that are going to come from this strategy. And that will, in part, come from the communication programme and awareness programme that we put alongside this.
Thank you, Martin. That's it timely, because I was going to bring in Charlotte next, so hopefully Charlotte can pick up on some of the comms issues there.
So shall I answer that and then make my point? So I think communication will be important, but it's also the engagement part, isn't it? So in the strategy, so, you know, you have been out and talked to communities about the services that they expect, and I think the implementation will be very much sort of at PCN and local GP practice levels on the implementation and getting that constant feedback around are we doing the right thing? Is it landing well? So I think our approach would most likely be we have sort of core consistent South West London communications, but it has to be localised for PCNs and local practices because they know their populations best and where they need to focus. The point I wanted to make was, you know, we know that many of our local communities are absolutely crying out for that kind of digital online interaction because it matches what they do in the rest of their lives. But I know that my Health Watch colleagues, who may choose to comment later, will be very concerned about our populations that are digitally excluded. And I know that you have thought about this. I suppose for the people who might be watching online, can you offer any reassurance to our older, more vulnerable communities who can't access, and they are in a smaller minority, but who can't access those online services, and how we'll make sure that we protect them and give them the same level of services. So just to sort of say that on behalf of my Health Watch colleagues.
Thank you, Charlotte. I'm going to come to Ruth next.
Thank you. I had 2 points, but just quickly to Charlotte, and I know you know this, Charlotte, that digital exclusion is increasingly less about age and more about deprivation. I think we all need to remember that. We're all getting older, and we're all sitting here with our clever phones and our laptops. So there is absolutely an age element to that, but increasingly, and we saw that during COVID, it's more about deprivation, I think, now than age. But the 2 points I wanted to make, one's about estates and the other about pharmacy. I'm really pleased about the initial comment you made, Mike, about where our GP practices are, and we all understand how this has developed over time. But I think if we were to look at a map now of where our GP practices are, we would say, yes, but they aren't in the right place. That isn't straightforward to resolve, so I just wanted to make a plug for local government that every borough has what's called a local plan. Sounds very boring. It's actually what we're going to be doing over the next 10 years in our boroughs, where we're going to build, how many new people are going to be coming into our boroughs, and by doing that we identify sites. Some of our boroughs across South West London are actually developing the next stage of their local plans now. So it's a plea to our NHS colleagues, please, to get involved, because now is a key moment when we can start to identify where the need is and what we can do about it. And we can do some quite clever things. So in my own borough, we are redeveloping a big commercial centre, and we're probably going to be moving the civic offices there, and there will be space for an NHS walking clinic. And I know we're already talking to our local partners about that, but let's be clever and innovative and make sure that we've got those places, those GP practices in the right places, because as you say, Mike, we know that at the moment it's not ideal. My second point was about pharmacy, and I understand, Nicola, we're going to be talking more about that as time goes by. And I'm really pleased to see the initiative that pharmacists are going to be asked to do more, because I think that is part of the solution to the huge increasing need on GP practice. I just wanted to say anecdotally, so my local pharmacist at the moment is busy giving a booster vaccination to over 1,000 people in my borough, and she's going into their homes to do it. So obviously that list of people has been provided by primary care, by general practice. I'm just wondering, that richness of information that those pharmacists will be finding as they go into people's homes and have those conversations and provide the booster, I just wonder how that's then being fed back into general practice, because I do think there's a real opportunity there, there's a contact, and I just want to have some reassurance that we're using that information in the best possible way, because I'm sure that going into people's homes, which isn't something that GPs are able to do on a regular basis, will provide a lot more information and possibly raise concerns about that person earlier on. So I'm just wondering how the feedback is going to happen about the information they're collecting. Thank you.
Thank you for that. And I think the point about actually making sure that we're coordinating where we place provision with our local government colleagues using their intelligence, particularly about future developments in localities and the levels of deprivation within those communities, absolutely vital. That is potentially one of the real strengths of the integrated care system that we have, that we've institutionalised those partnerships. I think it's really important that we make sure that we build upon them. And indeed, the question in relation, the specific question in relation to pharmacy, I'm hoping one of our primary care colleagues will be able to talk about how the feedback loop might work. So before coming to Sarah, I'm going to, oh, sorry, Mercy, I'll bring you in, and then I'll go back to Nicola and to...
Yeah, I was just going to, we've seen the primary care strategy because it came to the Quality Oversight Committee, and thank you for incorporating some of the comments we made, so that's really useful. I just want to talk a little bit about patients as partners as well, because it's really important that people actually know about things like multidisciplinary teams, the other professionals that are now available in many primary care kind of settings as well. And I'm pretty aware that actually many patients aren't aware, so not seeing your GP might be seen as, you know, kind of a deprivation really, and not really understanding the role of multiple disciplinary teams and things. So I guess it goes back to
the communication and engagement with communities as well, and how important that is on the delivery of this, because all these things are happening around people and they don't necessarily understand it or know about it. So just a plea really to empower patients, as Dick was saying, with information as well, so they understand what's happening around them.
Thank you. And Matthew.
Thanks, Chair. We've been speaking about this in primary care in Croydon. Obviously, we've had presentations on the strategy and supportive of it. It was interesting, as you say, Nicola, that the new national document came out 2 hours after you circulated the slides. But there's not an inconsistency at all. What I think is really interesting is the conversation we've just had chimes with those that I've been having with colleagues in my patch, that access requirement is not a universal consistent view. There are differences that people want and need, and we need to make sure that's reflected, and that requires us to engage with the patient population and the primary care themselves to make sure that that is reflective of what we actually need, rather than necessarily just saying, well, we've worked out this is what is needed and therefore that's what we're going to do. I know that's not the intent. We just need to make sure we challenge ourselves that we absolutely do respond to what is needed as opposed to what might be defined from afar. That's first point. And the second bit is none of this will work without the workforce, and primary care workforce is in a pretty challenged position, both in terms of numbers and in terms of workload, morale, etc. And I think that there is a big piece of work for us to do that thinks about the support to and the numbers of and the range of different individuals who can and do provide a role in primary care. This isn't just about GPs by any means. Very important that they are. There's a plethora of other colleagues, but with all of those, they similarly have workforce issues. So, you know, asking pharmacists to do everything, there are challenges in the pharmacy workforce as well. So we've just got to be careful how we play that out as well.
Really, really helpful comments. So before I go to Sarah, could I ask Nicola, Mark and Andy whether there are sort of comments in relation to things you've heard today?
So firstly, thank you to everyone for their comments, because that's exactly what we wanted. We wanted kind of a wide range of comments around the strategy and the next steps. I will cover off a few of them and then I'll hand to Andy and Nicola. But just to say, the questions around digital maturity, I do think that as everywhere, we will have different levels of maturity throughout the kind of primary care landscape, and there's something about our role in bringing that up to at least a standard that is that we would expect from our primary care. Really accepting that not everyone accesses care digitally. That's a really important caveat, but we could maximise those that can use digital much better. So I think we need to just always balance that conversation. And just in Ruth's comments, it is also about perhaps taking some digital solutions out to people rather than just kind of assuming that people don't want to use it. There's something about particularly our deprived populations and their access to digital. Workforce, I think everyone acknowledges the workforce challenges. We have a strong training hub in South West London, and we really need to maximise that training support and access across not just GPs but across practice staff. And I really welcome things like the shift to resources conversation. What I am hearing actually is that there is a step up in the ambition of this document, and I think we will take that away and absolutely cover that. One thing about IT, I will just want to mention, we need to give people the tools to do the job efficiently. We provide GP IT support, so again, what can we provide them? What is that consistent offer? And local estates plans are really, really important, because I think we've got a prioritisation process to go through that will be incorporated in the final strategy. But also really looking at the convergence between strategy and local strategy, and then the contracting mechanisms that we have with GP practices. Finally, information, shared records, and the ability for people to manage their own care, whether it be digital or whether it be in communication with the practice, is going to be essential. So I'm going to stop there and then hand to Andy, who will then go back to Nicola.
Thank you for the questions around the digital exclusion and also the use of the workforce as well. I think it's really, really important. And you know, the number of GPs we have has remained fairly static at about the 985, 990 mark for the past several years. And we've got about an extra 560 or so additional roles. And trying to explain those obviously is very, very complicated, which is why we need to be really simple in terms of how do we present kind of an easy access way in for patients. And the first thing to say is it is not at the expense of the traditional means of either picking up the phone or walking in. In fact, it should make that easier because people who know how to sort of access online NHS apps should be able to get what they need via a different route as well. So I agree, we need to make that absolutely clear about this one, and we will do. And of course, our PCNs, our practices do engagement all of the time as well. So the 40,000 surveys we had back in sort of last August, September helped informed how people want to access care, particularly of an evening, between Monday to Friday, along with a Saturday as well. And that work will continue, so it's not just a one-off and that's it, it's done as well. I do recognise in terms of digital maturity, 39 PCNs, whilst it's far easier to work with within 174 individual GPs, there is of course that variation, but they have all increased a substantial amount from where we were 3 years ago, which was really the start of the journey. What we all have to do, of course, is bring them all up to a good level, but I think we recognise with digital, things are moving constantly as well, so there's lots of talk about cloud-based telephony. You know, you can work in a GP practice, answer a phone 100 miles away, yet from a patient's perspective, it's absolutely seamless, and that will really increase the resilience and the ability of practice to work together. So we should improve the variation, because where you have practice perhaps struggling with workforce, they'll be able to pool some of their workforce to make sure that those patients get through on the phones that bit quicker as well. And of course, all the work we do through Charlotte and Charlotte's amazing team around the NHS app as a single front door for primary care has really been something that the NHS have been keen to plug for the last 1 or 2 years, and I think that's where it'll be headed for the next 3 to 4 years. So there is an expectation that by the end of this year, I think 90% of patients should be able to access their future medical records online as well, and do things like check organ donation, repeat prescriptions, all those kind of things as well. So we just need to be keep on the journey really. And if there's any extra information you want, we're more than happy to share that with you, because we do have a lot of change managers with our 6 federations working with each PCN as well.
Thank you. Yes, so thanks everybody for your comments. There were no massive surprises there, I'm glad to say, but actually it's really helpful to have some of the thinking that we've got reinforced and to understand where your emphasis might be. I think that's going to be really helpful to us. You know, general practice could be absolutely rock solid centre of a lot of the other care that we offer to our residents in South West London, and it's really important that we get this right, and the rest of the system needs to support primary care so that primary care can support the rest of the system. So those interfaces between all of your organisations and the bits of the system that you represent are really, really key. So we'll look forward to you know, moving on to next steps as well. I think Andy wants to say something. Okay.
Thank you. Just on next steps, I think it's really important to say that this is not just myself, Mark and Nicola here, but this is the culmination to date of dozens of people across the ICB, of course reflective of the work in primary care as well. So across all of our 6 boroughs, we're doing a huge amount of work on what we're calling delivery plans, particularly around access, prevention, proactive care, and once for South West London initiatives around digital and workforce where we can work together better. And what we're going to be doing is they will take it through their local governance structure every month, and then we'll bring a highlight report to SMT, and we'll absolutely accept the challenge that you made about trying to put some tangible, so how do you know when you got there as part of it as well. Thank you.
Sarah.
So firstly, I'm really pleased to see this. I think there was concern when we moved from CCGs to ICBs that actually the focus on primary care would be lost. And I think it's really important that we as an ICB are seeing a primary care strategy that we can take forward, because general practice and primary care as part of integrated teams locally is core to what we need to do both across the NHS and with local authorities and our partners. So I think it's really important that we've got this strategy, so I'm really pleased about that. I'm really pleased we also have good primary care, but I would also highlight that there will be areas where our local people say, actually, I can't access my GP, or actually it's in the wrong place, or actually this is really difficult and I'm not getting the service that I need. So I think sometimes the high level good masks a little bit of some of the pockets that we have in there, particularly in our deprived areas. And so I'm looking forward to finding out how this strategy will help us to address that and how we actually make those improvements, particularly around estate, particularly around how people access services. So I think it would be really good to bring this back when we've got the delivery, because I do think the delivery plan is key to this, and actually addressing some of those issues and using this as a kind of springboard to us delivering some of those improvements where they're needed, but also supporting some of the really good primary care that we already have in South West London to take the next step. So thank you.
Thank you for that, Sarah, and thank you, team. Many of you will know that yesterday our new regional director, Caroline Clark, was announced for NHS England. In my early conversations with Caroline, she has made the reinforcing the role of primary care one of her key goals. So that has been clearly set out. If we hadn't produced a strategy, I would expect that very shortly Caroline will be saying, where's your primary care strategy? So it's fantastic that we're ahead of the curve. I think, Mark, you said one of the things you'd picked up was about the level of ambition. And I would say, yes, this is great. It's good as far as it goes. We need to make sure we've got the scope, including pharmacy, optometry, dentistry within here, but actually that we are being really ambitious in our aspirations for primary care moving forward. Thank you all very much. We note the progress so far on the primary care strategy. Moving on to the Green Plan, again, absolutely central to our role as an ICB and sits very firmly within our fourth statutory objective. So Helen, over to you.
Thank you, Chair. I'm very excited to be here today to talk about the Green Plan. In the NHS, the Greener NHS strategy was launched in October 2020, and as part of that it was mandated that all NHS trusts and ICSs had to start to develop their plans, and I'm happy to say that our first plan was agreed by the former CCG board in March 2022. And here we are today reporting back on the achievements that we've made as a system over the last year and look to focus onto the next 2 years and where we want to go. I think the key thing for us is that we came together as a system and started to develop our sustainability network to be able to bring together our colleagues from across the trust, but also local authorities and primary care. And whilst our main carbon footprint may sit in the trusts, I think it's really important that we work together as a system as a whole. And I think our reflections on that is that there's more work to do there, but we want to continue to do that as we go forwards. I think really key to note as well is that we've been developing the ICP strategy, and obviously the development of a sustainable system is keystone to that. We want to make sure that the NHS part of this in our plan as we go forward really helps and supports that as we go. So what have we achieved in 22-23? Well, some great things across the patch. We've managed to develop electrical fleets, have more electric charging points, do more cycle to work, and really focus down on our anaesthetics, on our gas usage, and be really leading the way in reduction in desflurane usage, which is great and exciting for as we go forward for both our patients and populations. As we go forwards, we've worked to reflect on what we've done in year and where we want to go and what do we need to focus on in the next 2 years. So we've co-designed the plan in here with all of our sustainability leads and representation across the patch. We recognise we need more staff engagement. This is a time when it's been really difficult for staff within the cost of living crisis, within the strike environment that we're in, within COVID still here in the background, and the winter pressures that we've seen. But this is a really engaging topic for them that really empowers people as we go forward. We really need to harness that power to be able to support our population and our workforce to be able to drive things forwards. We need to make sure that we improve our carbon literacy and want to have an increased focus on that in the coming year to make sure we really understand our footprint so we can be more specific in our targeting. And then we want to collaborate and share better. So I will leave you to read the documentation and not take you all the way through the detail of the plan, but what we really wanted to do was bring to life some of those achievements. So I'd like to introduce Jenny Dorman to start with, who is the Estates Director at St George's, who can talk about the first reduced carbon menu for patients and the impact that's had.
Thanks, Helen. So it's a pleasure to be here today and to present to you. And in the pack is a very highlight report in relation to what we've been achieving at St George's on the Tooting site. What I will say is the Green Plan is an integral strategic objective for both the group and the site teams, and is very much within our new clinical strategy, which was launched yesterday. So I'm very pleased to say that we have significant engagement from the senior teams in driving this forward. This isn't something that we can just do in estates and facilities on our own. We clearly need to link and work with our teams, including our therapies teams, specifically around dietetics, in relation to making sure that we're meeting our nutritional standards. And as some of you will know, or hopefully all of you will know, the new NHS food and drink standards were launched last year. And obviously this is an integral part of the work streams around food and drink strategy and delivery to our patients across the board in relation to meeting our net zero challenge. So we have a 2-week standard menu cycle within the organisation, and we do also run a number of other specific menus to meet some of the needs of the populations we serve. We clearly have a very diverse group of patients that we serve each day, as you all know, from working within our space. We reviewed the high carbon footprint menu items on that 2-week menu cycle together with our partners from Appetito, who are our main patient meal provider, and Mighty, who oversee our patient catering service. And we came to a conclusion around an agreement of what we wanted to do and the aspirational target of trying to meet an 11% reduction in our carbon from those dishes. That was also put forward to our patient partners, and we have a patient partnership and engagement group within the organisation and our place assessors. Patient meal tastings were carried out in relation to making sure that those quality standards were maintained and that satisfaction levels were also reviewed. So we successfully did that. We trialled it over a period of time. The patient menu's been in place now for over 6 months, and we've actually been measuring that satisfaction as well as reviewing quality against those standards that we know we have to achieve. We came out with an 8% reduction overall, which clearly wasn't quite where we wanted to be, but I think still a pretty significant achievement from zero. And I think it's also proven that there is significant engagement across the whole of the population within the staff groups, patient groups and visitors in relation to doing more on this and trying to progress it forward. Getting to a net zero carbon position within the patient meal service will be a challenge, and we have to consider both the financial challenges we're in relation to investing in that service to meet that. However, there are other efficiencies that we know we can drive through the service to help offset some of those additional costs that might be needed. And within the pack, there's a table that just shows you that the cost neutral position, but also if you were to invest a little bit more, the achievement that we might have been able to achieve had we had a little bit more investment at the time. But again, that's part of our budgeting processes, and we'll work through that as an organisation. There's some examples also of kind of the offset for that. So as you can see, some of the statistics around how many trees that could be planted and some of the offsets with smartphones, etc. And I think one of the key things that I was very pleased to see was the significant improvement in patient satisfaction. Ultimately, we are here to serve our patients. We're here to make sure that the food and drink is of the best standard we can. And as we all know, malnutrition leads to extreme lengths of stay if it's not managed correctly and patients are not supported with their meals through hospital. In addition to that, we're also working with additional stakeholders in relation to the community. So we want to try and take out to our GP networks to make sure that people have access to this information, not only just for net zero, but also the menus themselves in relation to being able to see what's available before patients come into hospital. I think sometimes that expectation is there. We all know that unfortunately the media doesn't help us with some of that. You know, I can't sit here saying we're 100% perfect all the time. We're learning all the time. But actually we need to make sure that we're letting people have that access to those menus before they come in, as well as our own intranet and internet access that we have already. So we're doing some work on that this coming year. Next step in relation to the net zero agenda is really looking at the other menus that we're doing. Our phase 2 is also looking at staff engagement, training, carbon literacy. As Hans already alluded to, we need to do some work around reporting and recording. We have had a visit from NHS, from Philip Shelley, who leads the national campaign for the food and drink programme. We are pushing to be an exemplar site. This isn't just around patient catering. This focuses today on patient catering, but we're also looking at staff and visitor catering, as you would expect us to. And we're very keen to develop that, but there is a bit of a list waiting for that to be awarded, but we're definitely pushing to be an exemplar site for the NHS. We will continue to work with our patient partners. I think it's absolutely integral that we get that feedback on a regular basis, and we'll be driving to see what we can do to get to where we need to be by 2040. Thank you.
Thank you, Jenny. And then I'd like to ask Vanessa if she'd like to come in and some of the highlights of your builds and your new builds that are coming up.
Thank you. I'm sorry, Ian couldn't be here today, so you're stuck with me talking this through with you. But he's actually presenting at a national conference on our work around anti-stigma and anchor, so he's got a good reason. But you've got the slide pack, but I suppose there's some key highlights that I just wanted to draw out. So many of you will have seen at the bottom of stairs the kind of sign that says if you take these stairs, you burn 20 calories or how many calories. Our new building has 200 stairs, but actually it's not just about your health and well-being. Actually, by taking the stairs, you don't use a lift, and you save energy. The paint that we've used in the new hospital absorbs carbon, which means from the atmosphere as part of our carbon reduction. So it just proves that the technology that we use is not just mechanical, it's about the ability to use it in every step of the process. The atrium, so the big hall, thing that you walk through, has a complex cooling system, so it provides all of the air conditioning. So we have no powered air conditioning. It's completely used through a heat exchange, and that provides both our heating and our aircon, which means that we can create cool, comfortable environments for people. The ponds in the new park take the rainwater to prevent flooding, but it also meant that it's creating a biodiverse ecology, so it supports the geese, of which we have 125. Sarah's met the geese. 3 Canada geese, three Egyptian geese, but the rest Canada. But it also meant that we didn't have to, during the process, we didn't have to dig up the surrounding roads, which meant that we saved carbon materials and machinery. Overall, we didn't move anything off the site, so we were able to upcycle or recycle, so the bricks from the old buildings have been used into the parks, etc., to create that. And the parks itself creates the biodiversity and well-being and sustainability for the wetland areas, as well as creating great spaces for people to be. So everything that we've done has dual purposes. In addition, when we've completed the building, not only will we've reinvested over £1 billion back into South West London, the new Springfield Village will be home to more than 5,000 people, 4,000 residents, 1,000 patients and staff. So maintaining communities and reducing traffic is important, as well as affordable homes. And we've done that by reducing the travel times, by opening up the boundaries of the site. We've created affordable housing to reduce the travel times for families and friends to be able to access our buildings. And also we've created cultural activities through amphitheatres, wellness trails, without the need for people to get on public transport or any form of transport to do it. So I hope that just gives you a few bits. We've had a unique opportunity through this build. I recognise not everybody has that same opportunity, but actually that opportunity is being created by the ICS, by the providers and people around this table. So thank you for that.
Thanks. So I think hopefully that gives you a flavour of some of the exciting things we've been able to do to date and some of the opportunities it gives us to work together collaboratively as we go forwards. Happy to take any questions.
Helen, thank you for that. And Jenny and Vanessa, thank you for the case studies. It's really interesting. It really makes things come alive and shows the opportunities in things as varied as catering to estates, the opportunities that we can make to impact. I think some of the detail and the information within the strategy is really, really fascinating. I think it's really important that we remember that it's not just some of the things that we do in terms of multi-use equipment, etc., or the obvious, district nursing driving between patients, but it's actually a whole range of other areas like patients coming to hospitals, which can be reduced by things like virtual appointments. But when you consider that 23% of all travel in London is actually NHS related, you can see the huge scope. Now, 8% of that is our staff going to and from work, but the rest is our patients and their visitors coming to see us. So the way in which our acute services organise things like outpatients and diagnostic tests, if you do all of your appointments on a single day, that is just 2 journeys, one there and one back. Unfortunately, that's really unusual. They tend to be 2, 3, or even 4 visits on different days to get different sorts of tests. That's 8 journeys. It's also really difficult in health inequalities terms because maybe all of us can take time off work and get paid, but many of the people that we need and want to be using our services can't. So we need to be thinking of that in the way in which we organise our acute services, in fact, all of our services. I think it's a great plan. I think you've made it come alive with 2 contrasting examples of what we can do. Could I ask for comments from colleagues or questions? John.
Just an observation. Clinicians are incredibly busy, but actually when you talk about green, it's one of the things which actually engages them. So I think there's a real opportunity with clinicians right across, whether it's primary care or the acute sector, to think about this stuff. And I think, look, I'd have to say I was ambivalent about climate change maybe 10 or 15 years ago, and I've woken up to the risks. And I understand in terms of our infrastructure, whether it's digital or our estates, that we really need to do something around green and just accept the opportunities here, because if we don't, we'll be thinking about how we design our estates to adapt to the inevitable climate change that we've got. So this is, I think, is sort of, it sounds like it's simple stuff. It's not. This is complex change, but it's certainly worth investing in terms of financially, but also supporting our people to do it.
John, thank you for that. I'm looking at Charlotte because I share your view that this is an animating issue for many of our people, be they clinicians, but I think some of our, particularly our younger staff, see this as a really important symbol of how we want to move forward. And Charlotte, I wondered if you've got any views about how we might boost our engagement, particularly with our staff and with our communities around the green agenda.
Yeah, I think we're pushing at an open door, aren't we, really? So we do meet collectively as a provider, directors of comms group, and it's one of the things we're talking about a lot. I think one of the things that would be good to do would be to share that best practice, you know, between our different parts of the system, because I think there's a lot of good work going on in pockets, and I think part of the communications job is to say we don't have to reinvent everything from scratch. It's about sharing best practice in terms of staff engagement, but of course the broader agenda. So I think our communities, we know from all of the engagement work we've done with communities, is very important to communities, and sometimes we forget our staff are actually part of the community. So I think we're pushing at an open door, and I think the case studies bringing it to life are a great way to communicate because it makes it feel doable. I think a lot of the issues with climate change is it feels such a massive problem and people just don't know what they can do, but the case studies that you've brought to life show that we can, you know, all make a difference. So we'll be working on that.
Thank you, Charlotte. In terms of, sorry, Annette.
Thanks, Mike. I was just going to comment, Helen. So I think it's it's really interesting to see what's all been done. Really interesting to see the case studies and the plans for the future. I'd like to challenge for a little more primary care in there. I think there's more we can do to help primary care to understand how they can make greener choices, both for them and help their patients to use greener forms of transport. So I think things like bicycles, secure bicycle racks, and for staff and for patients, so fitting solar panels, LED lighting, etc. Choosing, I mean, something as simple as choosing a renewable energy supplier, you know, something really easy to do that can make a difference. And I think it's sometimes, as I think John said, there's not a lot of time to do the research, not a lot of time to get different people to give you quotes, not a lot of time to know who the best companies are to go to just help you to do something simply and in the right way and to choose products. So I think if there is a resource we could create or some information that we could get out to primary care, I think a lot of, it would be very popular with staff, but a lot of primary care practices would be very interested in doing that.
Thank you. Primary care is definitely one of our focuses for this coming year. We recognise that although we had light touch and some representation, it's been very low and limited, and so actually we really want to focus on working with you and supporting that.
Nicola.
Can I just go a step further and say you should be asking us to put a chapter in our strategy for primary care?
Please, can you put a chapter in your strategy?
What a great idea, Nicola. Thank you. And, Jenny, Helen, Vanessa, did you want to say anything in conclusion before I come to Sarah?
I think just to say that we're also very keen to collaborate with our local communities, and we've already started that work with the ICS in relation to the networking we've been doing. Obviously, we have Emma Evans, who's the South West London clinical lead for the ICS anyway for this topic. So we, going back to Charlotte's point, very happy to do some work and help and support colleagues where it's helpful.
And the what was the London Recovery Board, I'm not quite sure what we call it now, but the Mayor is very, very keen to support this agenda, and therefore, you know, that's another set of resources that we can bring to play for South West London. Helen, do you want to say any concluding comments?
No, just thank you for all your comments and support, and I think we look forward to working together with all of you and bringing back to the board an update on what we're starting to achieve during 23-24, if you'll approve the plan.
Sarah.
So I can remember us doing, pre-2019, doing all those tests around a pandemic. Do you remember those? And we never thought it would actually happen, did we? We all kind of like did those. I put my hard hat on and my yellow vest, and we'd all go sit in a room and get calls from somebody telling us that, you know, there was a pandemic going on and what we were going to do next. And then it actually happened. And I do think that this is the kind of pandemic that's coming towards us, isn't it? The global warming. We actually saw the impact on health last year when we had that heat wave, and it was the hottest we'd ever seen, and that had a massive impact on people's health. We have a responsibility as a leadership group to make sure that we are all focused on this going forwards, don't we? So that's why it's so important that we have this here. And we also have a responsibility as an ICB around social economic support going forwards, as well as the health of our local people. So two really good reasons why this has to be a priority for us, and how we have to jointly show the leadership and put it into all our strategies, as Nicola says, and make sure we have a focus, because otherwise we could treat it a bit like the pandemic stuff we used to do, which was we ticked the box and done the bit of work that we said we would do, or actually we can take this as a real thing and say, actually it's really important as a group of senior leaders that we take this forward in South West London, and I think that's our job really. So really pleased to see it, and really great that we do take it seriously and take this the next step.
I think you can take that as support for the Green Strategy. I'm seeing no dissent, so thank you again for the work, and thank you for the case studies, really, really helpful to see. We are going to take a short break. If we can come back at 25:02, so that gives us about 12 minutes. 25:02. I am going to ask you all to come back on time. If you're all back on time, I might get them to turn on the mirror ball. If you're late, there's no chance. All right. Great. Well, welcome back, everybody. On the basis we're starting at 11:26, we're just 1 minute too late for the mirror ball, so apologies for that. Moving on to item 9 on the agenda. Karen, as I said at the beginning of the meeting, is unfortunately not well, so Sarah's going to lead this item. So if we could move straight on to the South West London Partnership Delivery Agreements. Sarah.
Thank you. I think we've lost a couple of people, so I was hoping Matthew was going to be here for this discussion. I'm sure he'll be back soon. So this is one of the first of the partnership delivery delivery agreements that we are bringing to the board. There will be others. So we do believe that we need a distributed leadership model in South West London. We cannot hold everything at a South West London level. And we will delegate both to places, so that's our 6 boroughs, but also to our provider collaboratives. So in the future, we will bring back agreements for our cancer collaborative, our acute provider collaborative, and our mental health collaborative. But for this meeting, we're bringing the place agreements, so for the 6 places. We've called them partnership delivery agreements because we can't actually formally hand accountability, but we can delegate some responsibility. So that's why we changed the name from accountability, because as an ICB, we still have to hold the formal accountability. But these agreements do actually form a delegation agreement for some funding and also a focus around the 4 key areas that place are responsible for. This agreement has been discussed with the 6 places and the place leads, and all of the 6 places have a governance structure set up to ensure that they can deliver on this. Our intent is that if the agreements are signed off, that actually the regular updates will come to my senior management team in order that we can make sure that they are delivering to what we've agreed. But we will actually bring back an annual report to the ICB itself so that the board can see that we are delivering what we need to deliver. So I was just going to pause there actually, because I don't think it needs too much from me, but I'm happy to either have some of the place leads to feed into their view, but also the view of the wider board.
Thank you for that, Sarah, and I think it would be appropriate to get 1 or 2 of the place leads to just make some comments. On the basis of you're not normally shy in coming forward, Matthew, I wondered if you might want to say something.
That's unbelievable. Thank you, Chair. So we've obviously worked on this with the team at the ICS and also locally, and we're supportive of this. I think Sarah's right. There's a need to make sure some of this is codified, but I would also say there's a need for us to make sure this is a living document and that we don't feel constrained by necessarily by what we've written down, because I think it will develop over time. The ICB is still relatively new in its formation, and how the balance between what happens at the system level and what happens at place level, I think we have to test ourselves and see what works, and then make sure that gets reflected in these agreements. But I think it is nonetheless important to have it because it gives us a guide for what we should do, and you'll appreciate the importance of making sure that that's understood locally in places, but that also places don't feel that they are being therefore sort of dictated and directed to, that they have the flexibility to deliver what they need to deliver in their space within their own accountabilities, whilst also getting the benefit of what we get from working collectively as an ICS. And I think that's what these try to do, and we are supportive of them and we've engaged with them. I do note with interest that PDAs are also public displays of affection, and perhaps that's a good title to have for them. So
in that light, Joe, what do you think about public declarations of affection?
I'm all for them. We've been heavily involved in this, the development of the agreement across both Kingston and Richmond, and supportive. I think, as Matthew said, it's helpful to have a framework which provides a bit of clarity for us as with partners to work on locally, but I think there's also enough flexibility in there for us to do what we need to do in our places as well. So I think there's been broad support among partners on this evolution, and given the position that we've landed in, I think colleagues would welcome a bit more clarity maybe on the commitment around the funding around sort of inequalities monies and the innovation money that we benefited from last year, which I think, although modest investment, really did make a huge impact locally, particularly with some of our partners in the voluntary sector, where a little investment really does go a huge way. So I think there's one plea that I've picked up from colleagues around the table, is that clarity and commitment around those streams of funding, albeit modest but hugely impactful, would be really helpful.
Thank you for that. Is there any dissent? Because I suggest we approve the PDAs and approve the recommendation in relation to the SMT receiving update reports. Sarah?
Can I just come back on the issue of the funding? So just to be clear, the innovations funding and the inequalities funding is actually led by the Integrated Care Partnership. That's the work that we've done, and at the last meeting we agreed 18-month funding for that, starting in October this year, so 6 months for this year and 12 months for next year. There were 2 reasons for that. One was to give a bit more lead-in time to people developing their bids for that money, because we know that last year it was very fast, and there were a lot of smaller organisations that found that quite difficult. So we've taken that feedback and we're doing that work. And secondly, that sometimes very short-term funding requires a bit longer time to deliver and a bit longer. So we have agreed the 18 months as well. So it'll be 6 months for this year and a year for next year. So that is agreed. We will get the process out to the system at some point because we've got a little bit more time now to get that sorted. But the team, at my end and Karen's team, will be talking to everyone in the system about that.
And just before formally signing off, Sarah, can I check whether we might include in scope the pharmacy, optometry and dentistry delegation moving forward?
So pharmacy, optometry, dentistry is currently run for us centrally at London level by North East London. This is the contracting part of it. I think what we need to do is work with them because there's a formal contracting form, but there is a development opportunity, I think, for everyone around how do we deliver a more optimal service across those areas for South West London. So I think there's more work to do to actually work out whether there's any flexibility in the budget to do that. Definitely the way of working will be locally delivered. And I think that we would like to work, and I think I'll bring Mark in a moment, to develop that with places around what is the model that we would like. I think there's opportunity there with the delegation. We won't be able to formally delegate the budget because it's sitting at a London level for us. What we will be able to do is think about how we implement any changes in those services and how we develop those services going forwards. Mark, do you want to say something on that?
So I suppose just to add to that, the current model was about landing pharmacy, optometry and dentistry safely at an ICB level, and this is where the work really starts to begin, because actually we've got to, as an ICB, understand all the challenges that are in each of those domains, but also the opportunities for us as well. So I think this year that there's a piece of work really to embed that within the ICB, but also relate that into place.
Thank you. And I think, so clearly we will come back to that as we move forward. And I know from conversations with some of our partner organisations that things like children's oral health are incredibly high priorities and very different sets of needs in each of our boroughs. So it would be good to look at how we can use some of those emerging flexibilities moving forward. Take it everybody's content to support. Matthew.
Yes, Mike, but I should have added one extra point, apologies for coming back in, which is there are obviously differences at the moment in places, so we have some joint roles in Croydon that aren't replicated everywhere, and I think that is also another area where we need to make sure that we work those through to ensure that we can maintain both the value of what they are as we speak, but also they reflect the needs of the system and the realities of where we are in 2023. And I appreciate that may require some change, but what I wouldn't want that to do is to undermine the value of the joint arrangements that we've managed to create, because I think it's definitely delivered real value for us in Croydon, and so that's just a piece that we also need to work through in this space.
Helpful. I know that there's a commitment from Sarah to continue those conversations and make sure that we land an appropriate model. Okay, thank you for that. We approve and we the agreements, and we approve the reporting mechanism through SMT. Clearly any changes in relation to the issue Matthew raised, again, we'd expect that to go through SMT. Thank you. So we'll move on to the next item, which again, I think, Sarah, you're going to be speaking to, which is the South West London Anti-Racism Framework development, and really important area. I'm really pleased that Sarah has agreed to be the SRO for this, which I think demonstrates our commitment to the issue of anti-racism.
Yeah, so again, I don't usually present this much at board. It's just that I've had a few people not around this week. However, I think it was important for me to take on a leadership role with this. This has been very ably and led by Gloria Rowland, who was our chief nurse, and she's done a fantastic job in bringing everyone together. And when Gloria left, we had a discussion about who should then take on the leadership of this. And I think my view was that actually I should take on the leadership as the chief executive, because to show the commitment of the organisation to this as a really important part of what we do. I noted that in Mike's chair's brief, he referred to race action framework. I actually think that sounds a lot better than an anti-racism framework, which has kind of a negative view to it, and I think a really positive kind of race action framework. So I think we might change the name of it going forwards. But there is two parts to this. So one is what we're doing at London and what we're doing at South West London. So the first part is that Mike and I have been part of a discussion that's been had at London level with the Mayor's Office and also with the other ICB chairs and chief execs. And in here you'll find a statement that has been made by all of the London ICB chairs and chief execs around our commitment to anti-racism and to the communities that we serve. So I'm hoping that the board will also take up that commitment as part of what we do in South West London. The second part of this is that the work that's ongoing, that obviously I haven't been, I've been involved in it as chief exec, but I haven't been part of leading, and has been led by the team, and I thank them all for the fantastic work that they've done, to actually develop a way of working for South West London. And what that involves initially is a kind of assessment of where we are. And it's working with the whole system, not just with the ICB. So there is an opportunity here for other organisations that are not part of the ICB to work with a company called Flare, who are going to do an assessment of where we are in our anti-racism kind of approach, and then think about what's the framework we then need to take the work forwards. So we are looking at a number of options around what do frameworks look like in other organisations. We're going to let Flare do the work, and we're starting off with the ICB staff, but also a number of other organisations in the system. And we're going to open that up to providers, to the voluntary sector, and to others. So that piece of work is kicking off soon, and we look forward to seeing the output of that. There's also some work being done for us around engagement on this, and there was a procurement that went ahead, and it was won by an organisation in Kingston in the voluntary sector who are going to do some engagement on this for us across South West London. So even though they're a Kingston-based organisation, the work that they'll be doing is actually across the whole of South West London, and they're going to feed into the work that Flare are doing. So I wasn't looking, I'm really happy to discuss this. Obviously, I'm taking this over, so this work is new to me, but it has been ably led by Gloria and the team around her. But we are looking to step this up as we go forwards. So we're asking for people to not just note the comment by the ICB chairs and chief execs, but also to formally commit, I think, as a board to this. Also to support the development of the framework as we go forward, and I would like to bring it back to the board when the Flare work is complete and when we've started to think about what the framework looks like. And I think, Mike, you're also going to be chairing, going forwards, the Inequalities Board, which will also help us think about the governance going forwards and how we might bring that maybe into more focus by reporting directly some of this work into the board rather than through a separate board. But we'll have a think about that outside of the meeting.
Sarah, thank you for that. Reminder, page, I'm not sure which page it is in the packs, but the appendices covers the 5 commitments, which are a leadership commitment, commitment to our ethnic minority workforce, commitment to target health equity, commitment to becoming an anchor institution, and a commitment to our local communities. And I think the discussion we've had on other items today reflects those commitments, but I think it's really important that we see those through a race action lens as well, to make sure that our global majority communities feel that we are actually operating on their behalf. I can see I've got a couple of comments. I think, Dick, you wanted to come in, and Ruth. Dick, sorry.
Obviously, welcome is really important, and I'll please you just to say that and move on. I just want to flag up.
Terribly sorry. having trouble hearing myself. Very much welcome this. Just wanted to very briefly, Mike, comment in particular on the commitment to staff and staff development. I'm conscious the issue of succession planning and staff development for career progression is an important one, and I'm a bit out of date now, but I know that there are boroughs in London, Lambeth, one that quite recently had quite a big program on this, and I wonder if Mike and Ruth may well be well placed to share ideas and background on how that's worked. But it can be a particularly important thing because often there's a ceiling that just cuts off, and people from disadvantaged communities don't get beyond that. Anyway, so there might be some sharing that's helpful.
I'm certainly happy to come to Ruth and Mike I'm very happy to come to Ruth and Mike in a moment, because I think that the experience of local authority colleagues is absolutely vital here in terms of moving the agenda forward. Ruth, if I could come to you.
Yeah, and as if by magic, there were two things that I was just going to update on in terms of the work that Sarah's team, particularly Melissa Berry, who's a real advocate of this work, has been providing regular updates to the People Board. And there were two particular issues that we just discussed at the last board, which I think are really important in terms of the support that we provide to our staff. So first is the Positive Action Leadership Programme, which is a system leadership programme to support black and minority ethnic colleagues in terms of their career development and developing future system leaders. And then I think the other important part of this is the Ask Auntie app, which is a new mobile app particularly for our international nurses to support them in terms of the welcome, the tools, the things that they need in order to feel supported as they join our different trusts. So that's been piloting and trialled, and it was great to hear those updates at the last People Board.
Thank you, Ruth, and that was really valuable sharing that with us. Ruth.
Thank you, and I really welcome this. We all know how important it is. And it's important that we have the commitment, it's important we have the strategy, but it's important also that there's action, and meaningful action that will actually bring about change. And there are already all sorts of opportunities for our own personal development. In my own authority, we're using reverse mentoring a lot, where senior managers, instead of be the mentor, become the mentee. And it's an opportunity to get into someone else's shoes and just understand the impact of some of this. But the point I wanted to make is that while South West London is special and different, much better, we are still part of London, and most of the issues that we are facing are common to the rest of London. I often have conversations with the leader of Barking and Dagenham and agree that our two boroughs are just so very, very similar. So I don't think we should kid ourselves that South West London is that different from what's happening in the rest of London, and that's an opportunity to share. So I sit on the London Health Board chaired by the Mayor of London, and I've spoken to Marie Gabriel in North East, and we've both asked Kevin Fenton if he can think about setting up a depository, a place where we can share not just good practice, but also stuff that hasn't worked as well. Personally, I think we learn far more from the stuff that hasn't gone well than the stuff that we're very happy to talk about. So I think it's really important that we do find ways of sharing good practice and stuff that hasn't worked. I'm really pleased, Sarah, that you're talking about the chairs together looking at this, because I think we've got an awful lot to learn from each other. And I think some parts of London are further ahead than us because of the history, because of the demographics. But let's recognise that South West London is changing, it's becoming increasingly more diverse. We need to keep up, and we really need to face up to the fact that we haven't stepped up to the challenge up until now. And we need to think about how we do things differently and what that looks like in practice.
Thank you for that, Ruth. Mike.
I think Ruth's probably said it all. I don't have anything to add, thanks.
Any other comments before I come back to Sarah? Sarah.
So I wouldn't want to underestimate the huge amount of work that's already going on in all of our organisations, as well as within the community. So, and we are doing actually in the ICB, we're doing a leadership programme for my senior management team and all of our senior leaders around how we provide leadership in our organisation and do it in a way that makes sense. Also, all chief execs I know around the room have been involved in a London-wide piece of work on anti-racism as well that we've been involved in around sharing best practice across all the organisations in the NHS. So I do think that part of the framework we would want to think about how do we share that best practice that we've got, all of us, in our organisations with others, and how do we make sure that we're all doing the absolute best we can in order to make sure that we've got equitable ways of working across South West London, and we're recognising the added benefit that our local people bring. And I do think that I would like the board to actually commit to the statement that we've made, and I'm sure that we would then take that back into our organisations, and as part of this offer any opportunities that we develop to everyone within our system.
Thank you. So an ask to support the letter that both Sarah and I have approved with the other ICB chairs and chief executives, and an offer in relation to support and coordination. Clearly this links in with the individual res commitments that trusts will have committed to, but some reassurance, Ruth, in terms of the ongoing work. So the 5 ICB London chairs have discussed this on a number of occasions and will continue to discuss it and make sure that we're sharing best practice. And Caroline Clark, as Regional Director, will be reviving the old London Region Executive Committee, and both Sarah and I will be participating in that, and we know that Caroline is really keen that we have a strong race action commitment within that. So it's all very positive in terms of moving forward. I'll take this as endorsed. Thank you all very much. We're now going to move on to item 11, and this is updating the terms of reference for the Audit and Risk Committee. So Martin, if I could go across to you.
Thanks, Mike. So we are seeking approval for slightly modified terms of reference for the Audit and Risk Committee. 2 things to note. Moving to a frequency of 4 meetings per year to fit in primarily with our audit cycle. Second thing is for the committee to nominate a replacement for me as chair if I'm not available because I've gone under a bus or because I'm conflicted with on any particular item. So happy to take any questions on that.
Terms of reference are always the most exciting part of a meeting. I'll try and keep the debate to a minimum. Can I assume that everybody's happy to support the changes in terms of reference? Fantastic.
Thank you.
You've got your changes, Martin.
Thank you.
We'll now move on to the Integrated Care Partnership, the ICP Board report. Ruth, over to you.
Thank you, and you've seen the report, so I won't go through it in detail. We've done a lot of work on the discussion document. It's been a real opportunity to have a proper conversation with our residents, and this isn't a final document. It needs to be a living document as we continue to have that conversation. And I'm really looking forward to working closely with Zara and Elisa as we go forward and thinking about how we can ensure that we have that real reach into the community. But it's interesting to see, if you look at our main priorities, how much that resonates with the conversation that we've had here at the board this morning, tackling and reducing health inequalities, preventing ill health, promoting self-care so that people can manage their long-term conditions, a real emphasis on the health and care needs of children and young people, positive focus on mental well-being and community support for older and frail people. And we do have these overarching commitments around equality and diversity, championing the green agenda, which we've spoken about this morning. I'm really pleased to see that's absolutely on our agenda. And the voice of patients and carers and community voices. I'm really grateful to you, Charlotte, for all the work that you're doing with your team to ensuring that we are really reaching out and encouraging people to get involved. Some of us have been very involved in various reorganisation programmes, Sarah, haven't we, over the years? This is a real opportunity now, I think, to have a conversation which isn't just about talking a big strategies, but it's actually showing people what that will look like in practice. So I'm very excited about the conference that we're having on the 24th of May. There's a lot of people invited. It's going to be a real opportunity to start to think about what does this look like in practice, and my expectation of that conference is that we're going to have a significant move forward in terms of action and what it means to put those strategies and principles into practice. People want to see action. They want to see, that all sounds fine, but what does that mean to my life in my world? So I'm really excited about that opportunity. But the point you covered quite quickly previously, Sarah, about the Innovation Fund, I just wanted to very quickly focus on that, because at the last partnership meeting, when we talked about the potential of the Innovation Fund to involve smaller groups in the community that have that reach and come up with new and exciting ways of helping us achieve our ambitions. We recognise that last year we started quite late because we were just setting ourselves up and we didn't really give people enough time. There was a bit of discussion about how we're going to ensure that we do this properly this time, and I'm grateful to you, Sarah, and your team for having that flexibility to agree to the 18 months. I know that wasn't the idea originally, and I think it was a small demonstration of the fact that we are listening to what people are telling us and reacting as a result. So again, I think there's real opportunities here, but I'm looking forward to working more closely with Zara and Elisa, because I think you are most definitely part of the solution, and we need to think about how we use the skills that you have, the reach that you have into the communities, into putting this into practice. And I think that's all from me. Thank you.
Ruth, thank you for that. And one of the fears I know when we were setting up the architecture between the ICB and the ICP was that their agendas may drift apart, and the ICB may not take the proper account of the issues being raised by the ICP. So it's incredibly encouraging to see that really, really close alignment. I think that's testament to the leadership that you've placed in undertaken in that role of ICP chair. So big thank you for that. I think it's also a testament to the way in which the executive at the ICB has responded and ensured that we're capturing it. So I think we just got to keep that going, but it's really encouraging to see. Any questions for Ruth before we move on? In which case, move on to the board committee reports, and we'll take them in order. So first of all, Dick, could we go to finance and planning?
Sure. Yes, just to comment briefly on the paper, I'll just highlight a couple of things. You'll see at the March committee, two things I'd highlight. One, large number of single tender waiver documents that we had to process, which is something that makes me want to report to the board that I'm very pleased that the audit committee are looking at this, that we've had reports back on how to manage this process more effectively, and thanks to Helen and her team for really good work that you've been doing to make sure that we are more effective about that going forwards. For me, it was also an experience which I fear everyone else around the table will have had before, of the pressures generated from the national level of the NHS when it's near the 31st of March. I'll move on. April, I'd just like to flag up, we saw the Green Plan, which we discussed. The operating plan and the recovery plan were part of the discussion, and I do think that flags up something that we touched on as we went through the discussion of the primary health strategy and indeed mental health strategy. The scale of the financial challenge we face that's built into the operating plan and that's underpinned the longer-term two-year move towards break-even really highlight the scale of transformation that we're collectively going to have to address. And for me, it was very good to hear the quality and depth of collaboration that's happening already. I suspect we're going to have to work on that, and we're going to have to tell the public the story of how we could get to better care that's more cost-effective. That's all I want to say.
Dick, thank you. Helen, as the executive lead, did you want to add anything?
No, just obviously thank you to everybody for working together to develop the plan that we have agreed with NHS England to take forwards. We recognise that it is very challenging to deliver, and there are a significant level of risk in it around the level of savings that need to be made within the year and the inflationary pressures we face. But I think working together, we really want to make sure that we can demonstrate we've got strong financial controls in place. We continue to review strengthen those, and we look to improve our productivity to ensure that we can see as many patients as possible, but at minimum cost as we go forwards.
Thank you, Helen. And I think we probably ought to formally record our thanks both to your team, you and your team, but also to our Trust Chief Executives and CFOs who have worked incredibly hard to achieve the anticipated financial outturn. We'll move on to we'll move on to quality and oversight. Mercy.
Yeah, just a short introduction. We obviously meet on a bi-monthly basis, and we met in early April, and we're meeting next month. Just to highlight a few things, really, from my point of view. It was Gloria Rowland's last meeting, and we thanked her for her contribution. We obviously do discuss strategies before they reach the board, and we have a chance of interrogating them. So the primary care strategy came to us along with the primary care quality framework, which was really good to actually sort of see a framework where we can look at quality across primary care. And so that was a great synergy of actually two documents coming together. We also not only look at performance indicators and quality issues that are raised, but also often annual reports and areas where we kind of deep dive. So there was safeguarding review that came to us, and we were able to follow up issues and reports that have been raised before. And we also looked more kind of deeply at the Integrated Medicines Optimisation Committee annual report too. So there's nothing else I particularly want to highlight to the board. Perhaps John and Jonathan, as the executive leads, might want to comment.
So, John, as our Executive Medical Director, would you like to make any comments?
Thank you, Mercy. Thank you, Chair. So just in addition to that, just to note that the ability to access specialist CAMS practitioners in our ED departments across South West London has been improved. Now, that is a positive step, but bearing in mind the conversation we've had around the strategy with regard to mental health earlier on in the morning, the key thing actually is to take that need out of our ED departments, but we have to start somewhere, and if the first step is to improve that quality of experience for children and young people with extended hours, that's great, but ultimately we need to shift that activity into a place for children and young people, which is not an ED department. So I think I'll just leave it at that in terms of happy to take questions.
And Jonathan.
A couple of points, if I may, Chair. Sort of three areas I wanted to particularly draw out of the report in terms of improvement. So for patients with serious mental illness, the performance on health checks is now very close to the national expectation, and that's a big step up from where we were in the last quarter in terms of those patients accessing the 6 health checks, as was touched on in the primary care strategy work earlier. So I think that's important to call out. Access to diagnostic services, so important to patients, is the best it's been in a year, at 89% achievement against the standard. So that's some real progress, and thanks to Trust colleagues and partners, and supported by the new community diagnostic centres for their work there. And on cancer performance, patients who know whether they have cancer or not within 28 days of referral, that's now above the national standard, with one of the few ICSs in the country who are above that, achieving 79% against the 75% standard. So those are some areas of real progress and progression that we continue to see. In terms of areas of challenge, I don't think through the course of this meeting we talked about the impact of the industrial action through recent months, but of course I think we're all aware from the media and elsewhere how significant that has been in terms of keeping patients safe down through the urgent emergency care pathways, but also you can see some degree of impact on elective pathways through the figures presented here too. So that's one we'll continue to watch carefully as we see how further industrial action may or may not shape events over the coming months. Despite that, I would note that A&E performance, both in patients who've spent more than 12 hours in a emergency department and in terms of the 4-hour standard, have improved over the last month, which is really good to see. I would call out the challenges we've seen. A number of us talked at, including at the senior management team and chief execs meetings, on mental health services, which are a really significant issue around presentation in emergency departments, with a big impact on those patients and staff. Two, and Vanessa and I were talking in the break about what more we could do, as well as the multi-agency discharge events that are in place, and the commissioning of any additional bed capacity we can secure. Also, what's been done just in the last week or two around further stepping up and home treatment team resource and capacity to support work and discharge over the weekend. So very grateful to mental health colleagues for that work. But I would bring those two issues as areas of challenge to the attention of the board. Thank you.
Jonathan, thank you for that. And I think, again, highlighting the severe operational challenges of particularly the 2 junior doctors' strikes over bank holidays is a reminder for us to actually, again, note thank you to the chief executives and the chief medical officers of the trusts who worked tirelessly to ensure that there was sufficient cover and our services remained safe. Also worth highlighting, Jonathan, as you've alluded to, but South West London continues to be the best performing region in London in relation to elective care, and I think amongst the best in the country. That, of course, means that our patients are getting seen sooner than elsewhere, and that is really, really encouraging. And again, that's a big thank you to our acute trust colleagues for working together so effectively to deliver a strong elective recovery plan. So thank you for that. We'll move on to the next committee report, which is audit. Yep.
Thank you.
Martin.
Thank you. So you have the report. Just a couple of things to highlight. This year, 2 sets of annual report and accounts are being produced. The first for the first quarter of the year as South West London CCG. The second for quarters 2, 3 and 4 as South West London Integrated Care Board. So that's a huge amount of work, particularly for the finance team. So I wanted to acknowledge that. Both those annual report and accounts will be coming to the June board for approval by the board following recommendation from the Audit and Risk Committee. Look forward to that. Second is on internal audit. So our internal auditors gave us a draft of their annual opinion, having conducted a number of internal audit reports across the organisation over the previous 12 months. The final internal audit opinion will come to our June committee, but we're expecting that to be reasonable assurance, which is the second tier of assurance that they give. So top tier being substantial, then reasonable, then partial, and then no assurance. So we're expecting to get reasonable assurance. Substantial assurance across the year is very rare, given the breadth of areas that they review for us. So I think the exec team should take credit from getting reasonable assurance from internal audit for this year, given that we're a new organisation and quite a lot of systems and processes of control have been set up this year. That was the second thing I wanted to say, but happy to take any questions on the report.
Thank you for that, Martin. I think it's a good comprehensive report, and absolutely right to acknowledge the particular challenges that we face this year with 2 sets of accounts, the 3 months for the CCG and the 9 months for the ICB. Helen, to you.
I just also wanted to thank Charlotte and her team for all the hard work on the annual report. We couldn't do it with finance alone. We need to work together to get it done.
It's actually quite a good read, Charlotte. Well done. So thank you. Okay, we'll move on to the final one of our committee reports. And Ruth, remuneration and nominations.
Thank you. Very short update from me. So the committee met in May to ratify the appointment and salary of the new chief nurse for South West London ICB. And I'm sure all of you will join me in welcoming Elaine Clancy into that role when she starts in July 2023.
Thank you for that, Ruth. So we will move on to the Chief Executive's report. So Sarah, over to you.
Yes, I'm going to take most of the report as read, but I'm just going to highlight two areas, a slight updates and some more information. First is on industrial action. All of the providers and ourselves in the ICB have received notice from both the RCN and the BMA that the consultants and the nurses are being balloted shortly around further industrial action. We await the outcome of those ballots. That will take a little while to come through, and then they will need to give us 2 weeks' notice before actually taking any industrial action. But we will await the outcomes of those. So that's just happened recently. The second is I'd just like to remind everyone that NHS 75, so it is the 75th year of the NHS. There's a couple of things going on, but we are actually asking all of our staff about their stories so that we can feed into part of the celebrations. We've also been given a few places to go to Westminster Abbey for the celebration. We've offered those to some primary care colleagues and to some staff, so that we've got a very small number. Each organisation in the NHS have been given a very small number. It's not that big, Westminster Abbey, and there's quite a lot of us in the NHS. So there will be a few lucky people going along to the celebration, and there are other things going on. We will do our own celebration. I'm actually going out. I'm part of the leadership team going out to visit schools to talk about working in the NHS. So I'm going to go and do that. I haven't heard yet quite where I'm going, but I have said I'll do it. So that's going to be interesting. So there'll be a lot going on over the coming months.
Thank you for that, Sarah, and a timely reminder in terms of NHS 75. Any questions for Sarah on her Chief Executive's report? In which case, I'll go to our Voluntary Sector and Health Watch colleagues. So comments, questions, points that you'd like to make?
I'll go first. Hi, everybody. My name is Alyssa. I'm with Health Watch. Just going back, I wanted to extend my compliments to the writers of the Green Plan, the Mental Health Strategy, and the Primary Care Strategy. I think the parts of the report that highlighted the patient views is very powerful. Just one thing I wanted to suggest for further papers, and this extends beyond those particular thematic areas, is if you could take the patient voice and then link it to the ambitions, I think that would really support those strategies. It could be as simple as numbering the ambitions that you're listing in the strategies, and then next to the patient concerns, listing those particular numbers. And I think that would just help patients really feel heard. And Health Watch is going back to patients and letting them know how the ICS is responding to their concerns. I also just wanted to respond to Ruth Dombey's comments about the value of Health Watch Integrated Care Partnership. I just wanted to say we remain very committed partners, and we really look forward to supporting the delivery of the integrated care strategy, particularly in embedding the patient voice into those delivery items. And then finally, with regards again to the primary care strategy, really welcome the comments that I heard from around the table about plans for continuously monitoring patient views, particularly around new interventions that are aimed at increasing the accessibility of services. And just to say that Health Watch routinely collects data from patients. We have people calling us all the time with concerns about primary care services, so we can be a partner in monitoring that data. We're also planning a focused bit of research in the coming year. So again, really keen to help support that work. Thank you.
Thank you for that.
Thank you. Sara Milocco. I am the new director for the South West London Voluntary and Community Sector Alliance. I've got 3 questions. One is on the mental health strategy, one is on the primary care strategy, and then one is about the South West London ICB financial plan. So with regards to the mental health strategy, what I really was looking for while I was going through, it's an excellent strategy, is kind of more detail about the voluntary sector, because I know you've got services that are commissioned across the 6 boroughs. So what I was asking myself was what the impact of these services is and how is going to feed into your plans for the voluntary sector. So kind of into prevention, for example, and going back to Ruth's comment about, absence of school, there are voluntary sector groups, there are initiatives on the ground working in playgrounds, talking to parents about their issues. We know that mental health is all about sometimes housing, your financial situation, your kids, situation. Is that the kind of prevention you're looking to invest in? I just wanted those kind of that kind of direction when it comes to the voluntary sector.
Should we take?
Shall we take
Vanessa?
that?
Yeah, because it would be better to have a dialogue rather than a. So Vanessa, please.
Yeah, so thank you for the question, and it was absolutely intent to ensure that the voluntary and third sector were involved in the strategy. I don't think the detail of it is in there, but the way in which we will implement that is through the work at neighbourhood and place in particular, because of the way in which the third and voluntary sector sits within there, but also at the partnership delivery group now. We've got a third and voluntary sector representative, and I can't remember their name because they've only just joined us, but what I'll do is I'll link up with you to make sure that we connect that back across.
And on to primary care.
So the primary care strategy for me, what I really would have loved to see is a bit more about social prescribing, because I really think it's been quite a successful way for linking up with the voluntary sector. And again, I was asking myself, so what are the plans for the social prescribing? What was the impact? What are we doing about it going forward?
Mark?
Yeah, I think that's a really good point. We will make sure that social prescribing has the right profile in the next iteration of the document. I think there's a couple of things. We know that social prescribing has been really successful in some boroughs, and actually what we want to do is share that across the other boroughs as well, to make sure that it really is a kind of a central part of enabling the right care to be accessed at the right time for our residents. So I think, much as Vanessa said, there is some work around the implementation of that at a place level, and supporting the strategy. There will be 6 delivery plans at place, and we should absolutely make sure that social prescribing is both in the strategy but in that implementation plan as well.
Yeah, that would be great, because that's exactly what I had in mind. So if it's not in the strategy, how can I then go back and say, what has been done? But if it is in the plan, I would love to be involved in that. That would be great. Again, on social prescribing, talking about what Ruth was saying about, the vaccinations and people going into homes, that could be the link. The social prescriber is the person that can pick up the non-clinical aspects of people's lives, but maybe they can help with and refer into the voluntary sector, whether it's a walking group or, someone to help from Age UK at home or whatever it is. Yes, and then the final one was about the financial plan. And it was about, for me, again, with my voluntary sector hat on, I would have loved to see a breakdown of the voluntary sector commissioning into the budget, because what I'm looking at is different lines, and I'm thinking, okay, where does the sector, where is the sector is into community? I mean, obviously there are some lines that are not voluntary sector, clearly, but where is the voluntary sector here? Where is the commissioning in these lines, basically?
I'll get Helen and then Sarah to come in on that, but I think it's a really clear point, because I'm really keen that as part of that shift to a more preventative and anticipatory model of care, that we actually have a really strong commitment in our medium-term financial strategy to increasing the investment we're making in our voluntary sector partners. So that's my aspiration for not just this year, but for future years. And I think we need to be more explicit about that. But I'll ask Helen and then Sarah to come in.
Yeah, so the majority of the spend will be sat in the community care section. But I wonder whether or not we should meet up outside of here to go through the details so you could see how it breaks down.
Thank you for that. Sarah.
Yeah, I mean, I think it is difficult when you've got a kind of £4 billion budget to go down to that level because there's so many budget lines. I do think it's important that actually the majority of the work that we do with the voluntary sector is through the place. And the place regularly looks at their budget, so each individual place looks at their budgets. So I think actually if we involve the voluntary sector, which I think we are trying to do, in that local place discussion, that is really where we get the real benefit. And I do think there is a potential for us to work more closely as well with local authorities around how we commission the voluntary sector together, because I think there is real synergy there for both local authorities, the NHS, and for the voluntary sector in how we do things going forward. So absolute commitment, but I think probably what we need to do is link you in outside with Helen, but also into the places where they're actually doing that level of detail around how they commission the voluntary sector.
Did you have any other points at all? They were fantastic questions. Thank you for that. Okay, so we are at any other business. I haven't been notified of any other business in advance. I'm assuming there's no urgent business that people need to raise at this point. In which case I will bring the meeting to a close. I would like to remind colleagues that the next meeting in public will be at Clarendon Hall in Twickenham on the 19th of July. Perfect setting, not far from the river, so let's hope for a sunny day. And at that point, I close the meeting. We do have some public questions, I do believe. Charlotte, do we have questions from the public? Sorry, Ben.
So we don't have any written questions that were submitted in advance, Mike.
We've got at least one person from the audience who would like to ask a question. So please feel free to. Could you introduce yourself as well for the record?
Can you hear me? Yeah. My name's Wendy Micklewright. I hallucinate, I hear voices, but I'm not ill, don't take psychiatric drugs. Thank you for the points you raised about mental health, poverty and housing, which is what we hear all the time. And I have mentioned in this meeting before, 6 months ago, but I didn't hear anything about it today. The other thing that I really want to raise is the information about electroconvulsive treatment. And since I last raised it, the requirement to ban electroconvulsive treatment, there is an online petition with over 132,000 people saying that electroconvulsive treatment should be banned. And that really needs to happen. I think I'll leave it at that.
Wendy, thank you for that. I'm going to ask our mental health partner leads, Vanessa, to respond.
Thank you, Wendy, and thank you for your ongoing commitment to raise the challenges. As you know, board members, following the last time Wendy raised this concern, a briefing was sent to you all around electronic convulsive treatment, and that briefing has been shared in full with Wendy, and I recognise that we have a difference of opinion in this area, Wendy, but we have shared the full facts with the board.
Sorry, could I just say something?
Please do, Wendy.
I did mention the idea that lobotomy was acceptable 60 years ago or less, and it's fair enough to present information, but there is a petition with over 132,000 people have signed. So, I mean, the people are speaking, but...
Wendy, thank you for bringing that to our attention. We do note it. I suspect that Vanessa will bring the issue back to us if at some future point. And Wendy, I'm sure that you'll be at future public board meetings, and we'd be really happy to hear from you on this or on other issues as well. Are there any other questions from members of the public? In which case, I'll close this part of the meeting as well. And just to thank you all very, very much for your attendance, and very much look forward to seeing you on the 19th of July. Just a reminder for people, again, the event on the 24th of May, which is the ICP seminar, and I think it's going to be, as Ruth said, a really exciting and important event, and I hope I will see many of you, that we will see many of you there. Thank you.